Okay, please let me know. Is the audio clear? Yes, I can see. Is it clear? Amtul, yes. Okay, so good evening, everyone. In this session, INICET Predictor series of general surgery, I will be discussing like 15 questions. Okay, so let's see some of the questions which are like very high chances, like these topics they will ask in the exam. Okay, all of you have seen the questions. So let's start with the very first question. Patient presented to OPD with a history of incised wound 3 days back. On examination, there is a serous discharge from the wound. What is Southampton grade of the image shown below? You can see very clearly there is a serous discharge coming from this wound. And they are asking as per the Southampton grading system. Okay, as per the Southampton grading system. So see, Southampton grading, this is the Southampton grading. Southampton grading. See, normal healing when everything goes fine, there is no infection, no edema, everything goes fine, normal healing. One is there is normal healing with mild bruising or erythema. Okay. 2 is erythema with other signs of inflammation. First we'll see, like the minimum you have to know this. 3 is clear or hemoserous discharge. Clear, or you can say serous, or hemoserous means serosanguinous blood and serous mixed. Then 4th is pus discharge, and 5 is deep severe infection with or without tissue breakdown. Okay, so we need to know at least this much. Okay, this much, that what is 1, 2, 3, 4, 5. 0, 1, 2, 3, 4, 5 of Southampton grading. Okay, so because it looks like clear cut is serous discharge, so that's why it is grade 3. Grade 3. Now let's see, there is sub classification also. Like in this case, some bruising, considerable bruising, or mild erythema. Okay, so this is actually normal healing with bruising, or here comes mild erythema. Normal healing with bruising or mild erythema. Now in this case, erythema, other signs of inflammation, whether at one point around suture or around wound. Like suppose there is a sutured wound like this. Okay, so what is the meaning of at one point? Like suppose here is the erythema. Around suture means around the suture, and along wound means along the wound means this. It is along the wound. Okay. Similarly, the discharge, whether it is coming from one point along the wound or it is coming in large volume, and whether it is coming for 3 days or more. Pus discharge, whether at only one point or along the wound. Okay, so this is Southampton grading. And in the NEET, in the INICET, there were questions, like previously also they have asked question on this wound infection. One more thing I want you to remember, there is another thing related to the wound infection, asepsis score. Asepsis. Asepsis in itself is a, you can say, acronym or mnemonic, where A stands for any additional treatment, whether patient required any additional treatment in the form of antibiotics or drainage of pus or debridement. S stands for serous discharge, E erythema, P pus, S another S is separation of deep tissue, I stands for isolation of bacteria, and finally the last S stands for stay in the hospital prolonged for 14 days. See Sakshi, you have to remember this main 0, 1, 2, 3, 4, 5. Okay, if possible, try to remember the sub classification also, although I know it is a bit difficult, but if possible, try to remember. Otherwise, it is okay, but you have to remember what is 0, 1, 2, 3, 4, 5. Okay. So this is asepsis score. Now they give some points. Okay. The only question they ask is which of the following parameters is not seen in asepsis score. but still depending on the total points 0 to 10 they say satisfactory healing, 11 to 20, 21 to 30, 30 to 40. Okay, like this the scoring goes: mild infection, moderate infection, severe infection. Okay, so rather than that, just remember what does asepsis stands for. Asepsis stands for. Okay, so this question is clear. Serous discharge. So this is grade 3 as per the Southampton. Anything you related to this, any of these topics, you can ask me. We can discuss that also. Next question: which of the following is not true about vascular anastomosis? Okay, not true about vascular anastomosis. Just tell me whether the statement is correct or not. Only non-absorbable material is used. Okay, this is the correct statement. We use non-absorbable for vascular anastomosis. Intima is always included. Yes, this is correct. We should always take the full thickness. Multiple throws are required for the knots because we are using monofilament suture. So for monofilament suture, you need multiple knots. That is also correct. Okay, so let's see what is the suture of choice for vascular anastomosis. Anybody tell me what is the suture of choice for vascular anastomosis? It is polypropylene, which is also known as Prolene suture. A light blue color monofilament non-absorbable suture. Non-absorbable synthetic monofilament. Yes. Okay, now what is the size? That depends on the vessel in which we are going to do the suturing. Like for aorta, 30, iliac vessel, 40, okay, femoral, 50, smaller popliteal, 60, more small like hepatic artery, 70. Okay, so you can see this is the size. Now mostly we go for continuous suturing technique. For the vascular anastomosis, continuous. If it is a small vessel, also in case of children, we can use simple interrupted, but mainly continuous suturing technique is used. Now see, suppose this is one end of the vessel and this is the other end of the vessel. This is the proximal end, this is the distal end. You put a clamp on this. Now when you want to do this end-to-end anastomosis, see, this is a flow, this is how the blood flows. So when you do the suturing, see, your needle should go outside in, and then you come to this end, and then you go inside out. Okay, so in the downstream end, you are going inside out. Again, you will go in this manner. Okay, so remember, in the downstream end, you have to go inside out, not outside in. Because if you go outside in, there will be a little bit of intimal flap will be raised, and when the blood comes in that area, there will be dissection kind of picture. Okay, so that's why in the downstream end, you should go inside out. One more thing, when you do the suturing, suppose you have put the clamp and now you have done the suturing, just one more bite and your vessel will be airtight, watertight. This is the proximal end, this is the distal end. See, there is presence of blood here and blood here, but at this moment there is air inside this chamber. Okay, so you need to remove the air, because if it is an arterial anastomosis, even 2 ml of air can kill a person. So that's why today at this chamber, one of the ways you release one of the clamp. Remember, the distal clamp is released first. Distal clamp is released first. Okay, so remember these two important things. Let's see few more points which can be asked for abdominal wall closure. When you do a laparotomy for abdominal wall closure, the suture of choice is PDS, and the preferred technique is mass closure. Okay, we take all the layers, posterior rectus sheath and anterior rectus sheath in one go, and the distance between edge and needle entry, previously it was 1 centimeter, now they say 5 mm, 5 to 8 mm, the same distance between the next suture, that should also be 5 mm. Okay, and remember, for GIT, Vicryl, that is polygalactin, is the suture of choice, mostly 30, otherwise 20 can also be used. And the best is side to side anastomosis is best, and ideally it should be a single layer extramucosal, and simple interrupted. That is the best type of technique. Okay, so something about the vascular suturing and the other suturing. So the answer for that is suture material must pass from out to in. That is wrong. It should go from in to out in the downflow aspect. Okay, so that is the wrong statement. Okay, all good. Next, one of the very favorite, every year they ask question about this. PET sore, a patient with quadriplegia and ischial tuberosity is in fact the most common site, and extending into the subcutaneous tissue but not invading the deep fascia. So it has gone beyond the tissue but not going into the deep fascia. And what is the stage of the pressure ulcer? Okay, so tell me, it's very easy. 3. See, stage 1. Intact epidermis, only erythema. Okay, you can see epidermis is intact. Stage 2, partial thickness ulcer involving the epidermis and dermis. Stage 3, through the dermis. Okay, this is our question. Through the dermis into the subcutaneous tissue. 4, it has gone beyond the subcutaneous tissue, beyond the fascia, and it involves muscle, bone, and tendon. This is how it looks. This is how this looks. Okay, there is one more image. Can you see grade 1? The skin is intact. 2, partial thickness. 3, it has gone beyond the skin. 4, it has gone, you can say, beyond the fascia into the muscle or the bone. And there is one more. Can you see? There is a scab or eschar. That is, you can say, stage 5. Stage 5 is unstageable or ungradable. Okay, so this is the grading of pressure ulcer. Remember, the most common site is ischial tuberosity. And if somebody asks what type of edge you will see in this ulcer, edge, any ulcer which occurs because of the decreased blood supply, ischemia, the edge will be punched out. Punched out edge. It's punched out edge. Okay, so whenever this occurs in those patients who are like bedridden, so when they are not moving, so one hard surface is their bone, one hard surface is the bed. Between the bone and bed, the skin comes, and because of the pressure, when the pressure exceeds more than 30 millimeter mercury, the capillary blood flow stops, and then it leads to ischemia, and it can lead to this type of ulcer. Okay, so this is stage 3. Stage 3. Okay. Any confusion? In order to prevent this bed sore, you change the position of the patient frequently, every 2 hours in case of the supine patient, and every 10 minutes for the patient who are sitting on the wheelchair. Okay. Next question. The patient presented to surgical OPD with painless lump in the breast for the past 1 month. On MRI, you see a tumor involving lactiferous duct of the breast. So if it is involving the lactiferous duct, like this, involving the duct, which clinical sign it will result? If only image would be given in this question, how to tell the stage? See, generally in your exam, what they ask is, mostly they give a stage 4 image. Mostly they give stage 4. And how will you see stage 4? They will give something like this, in which the bone is exposed. So if they give the image only and the bone is exposed, it is stage 4. Now there are two things I have given here. Can you see? In stage 1 is fine, the skin will be fine. So 1 you can easily tell, 4 you can easily tell, 5 also you can easily tell. Okay, so there is no problem in 1, 4 and 5. Okay, Ridhika. Now the issue is in 2 and in 3. Okay, so what happens in 2? It will be a very superficial kind of thing, like as if there is a abrasion. Okay, it will look like an abrasion. Stage 2. Okay, it will look like an abrasion like this. And if it is a more deeper one, then it will be stage 3. Okay, where the skin will be gone and you can see the subcutaneous tissue, subcutaneous fat. So then it will be stage 3. Okay, so 1, 4 and 5 there is no issue. In 2 it looks like a superficial abrasion, and in 3 it looks a more deeper thing. Okay, all of you are saying for this question, when the tumor involves lactiferous duct, that it is it is nipple retraction. Yes, the answer is nipple retraction. Okay, tell me how this is. Tell me what is this condition. There are different presentation, like lump, which mostly occurs, most common site is upper outer quadrant, followed by nipple areola complex, and least common is lower inner quadrant. Lump will be hard, painless to begin with, and fixed to breast. Okay, there can be nipple discharge also. Nipple discharge. What type of nipple discharge? Single duct, single side, spontaneous, and serosanguinous. Then this condition, there can be one atypical presentation like Paget's disease, eczema like skin condition. This is the nipple retraction, and what type of nipple retraction? All around circumferential nipple retraction. Okay, when the tumor involves the duct. This is dimpling or puckering. Okay, this is seen if there is involvement of Cooper's ligament. And remember, this condition is known as podgy orange appearance because of involvement of superficial, or you can say subdermal lymphatics. Okay, then there can be presentation as ulceration, there can be satellite nodules. Okay, so all these things can be seen on the skin over the breast. Now I want you to ask one question. Okay, everything is clear? Anything you want to ask? Now, see, tell me, out of these, different skin condition in the breast cancer, which of this comes under skin involvement? Out of these, which comes in the skin involvement? Like for T4B skin involvement, what clinical features will come in T4B? See, remember, in T4B comes body orange, ulcer, and satellite nodule. Only this. Remember, dimpling, puckering, nipple retraction, Paget's does not come under skin involvement. Nipple discharge, only these three things comes under skin involvement. Yes. And this body orange should involve less than 1/3, or you can say less than 33% of the skin of breast. Because if it is more than 1/3 or 33%, then it fits the criteria of inflammatory breast cancer. Inflammatory breast cancer. Okay, so this question is clear. Next question. A patient comes to the emergency with road traffic accident. You notice that patient has retroperitoneal injury. Retroperitoneal area is divided into different zones. What is the zone of area B in the image? Area B. This comes under which zone? Zone 1, 2, or 3. What to do for satellite nodules? Satellite nodules comes under T4B, that is skin involvement. Okay, so all these patients, if there is satellite nodule, you have to give neoadjuvant chemotherapy. I mean, although that depends on the staging, but majority of the time when there is skin involvement, patient will be either stage 3B or 3C, and we go for neoadjuvant chemotherapy, and after the chemotherapy we go for the surgery. Okay, so this is retroperitoneal hematoma. See, retroperitoneal hematoma is divided into 3 zones. This is zone 1. In zone 1, the major vessels are there, like aorta and IVC. This is zone 2. Okay, the flanks is zone 2, where there is bleeding because of the renal vessels. And this pelvic area is zone 3, where there is iliac vessels. Okay, so when we talk about the treatment, if it is a penetrating injury, then surgery in all. If it is a blunt injury, zone 1, surgery. Zone 2, non-operative management. Zone 3, non-operative management. Okay, so only indication except retrohepatic IVC hematoma. Except in retrohepatic IVC hematoma, we do surgery in all. Non-operative management, surgery if expanding hematoma. That means there is active bleeding. And in this case, if active bleeding, see, this is the area which is very difficult to control surgically. So if active bleeding, we go for angioembolization. Okay, this is all you need to know about the retroperitoneal hematoma, its zone, its treatment. Okay, so zone 2 is the correct answer. Okay, it comes in zone 2. Now, one more question they can ask about this is when you go in the retroperitoneum and suppose you want to expose the IVC or the right kidney, then this maneuver is done, which is known as right medial visceral rotation or Kettle-Brash maneuver. And similarly for the left side, for aorta or the left kidney, you mobilize the descending colon and the sigmoid to the other side, and this is known as Mattox maneuver. And duodenum is also a retroperitoneal area. So in the upper part, if you want to expose either IVC or aorta in both, duodenal mobilization is known as Cocker's maneuver. Cocker's maneuver. Okay. Okay. Going to the next question. Any question, anything, any doubt you can ask me. At her follow-up visit after her modified radical mastectomy, the patient reports feeling a sensation of numbness in her upper inner arm. She has full motor strength of the extremity and the remainder of her arm has normal sensation. Her incision appeared to be healing well. What is the most likely etiology of this? Okay, so the patient underwent MRM. After that, there is only a small patchy area in her upper inner arm where she has, loss of sensation. Rest of the motor and sensory examination is fine, normal. What is the most likely reason for this? See, when you do a modified radical mastectomy, in this you have to remove the axillary lymph node level 1 and 2. So when you go for the axillary surgery, there are certain structures which should be preserved. What are the structures you have to preserve? Axillary vein, long thoracic nerve, and thoracodorsal vessel and nerve. These are the structures you have to preserve. There are certain structures which are preferably preserved. I mean, you should try to preserve these structures if possible. Otherwise, if these structures are causing your, it is coming in your way of dissection and you cannot do it, you can divide also. But most of the people, they try to preserve. That comes intercostobrachial nerve and medial pectoral nerve. Okay, now let's see. We all know that if there is injury to the long thoracic nerve, it will cause winging of scapula. That has not happened. If there is injury to the thoracodorsal nerve, okay, you can see these are the things goes. This is the axillary vein. This is the thoracodorsal vessel and nerve. Okay, this is the thoracodorsal nerve, and this is the long thoracic nerve of Bell. Okay, thoracodorsal nerve. This is axillary vein. So these things you have to preserve. If there is injury to the thoracodorsal nerve, patient will have problem in doing the backward movement because thoracodorsal nerve supplies the latissimus dorsi. Now, intercostobrachial nerve. This is a branch coming from the second intercostal nerve. Okay, second intercostal nerve gives this intercostobrachial nerve, and which crosses the axilla like this. Can you see? It is crossing the axilla in this manner. And this is the area where you have to do dissection. This is the area where you go for your surgery. So many times what many surgeons they do is, because it comes in their way, so they divide this. So when they divide, the only problem happens is, can you see this area? This is the cutaneous innervation. This part of the arm will have loss of sensation. What has happened in this question? Okay, so this medial pectoral nerve, nothing major happens. Medial pectoral nerve causes, it supplies the pectoralis major, nothing major happens. So this answer is injury to the intercostobrachial nerve. Injury to intercostobrachial nerve. Okay, so all good. Anything, any question in this? Clear? Okay. Coming to the next question, this is an easy one. A 24 French Foley's catheter. What is the meaning of that? Whether it is 24 centimeter long, whether it measures 8 millimeter in the outer diameter, or it measures 8 millimeter in the inner diameter, or it can hold 24 ml of fluid in the retainment balloon, or you can say the balloon which is used for the inflation or deflation. Okay, anybody, what is the meaning 24 French Foley's catheter? Okay, what is the meaning of French, FR? Okay, actually 3 French is equal to 1 millimeter, and this French is the outer diameter. Actually it is outer circumference, but yes, you can say outer diameter. Okay, so what is the answer? Tell me, what is the answer? It measures 8 mm in outer diameter. Yes, that is correct. 8 mm in outer diameter. Most common nerve to be injured in MRM? Yes, because we don't have to, preserve that. So if intercostobrachial nerve is there, yes, that is the most common to be injured. You can see 14 French. 14 French is equal to 4.7 mm. 4.7 mm. Okay, so 1 French is equal to 0.33 mm, or you can say 3 French is equal to 1 mm. And remember, for this Foley's catheter, for adult male, what is the usual size? 16, 18. 14, 16, 18. Adult female, 12 to 14. 6 to 10 French is pediatric, and more than like 20, 22, that is for clot retention. Usually these are 3-way Foley's. Okay, after some bladder surgeries or TURP, okay, or if there is hematuria, for that we use this. Okay, so the answer is B. Yes. With regard to the surgical safety checklist, sign in is done. When we do sign in, what is the time when we do sign in? Before skin incision, before induction of anesthesia, before patient leaves the OR, and when the patient enters the OR. What is the answer? What is the correct answer? What is sign in? See, surgical safety checklist is given by WHO. Okay, so what is this surgical safety checklist? This is the surgical safety checklist, so that these mishaps does not occur. Okay, so in the surgical safety checklist, there are certain things like before induction of anesthesia. Before you give anesthesia, the thing which we do is known as sign in. Okay, which is the question, sign in. Color coding of Foley's is not very important. These were the questions they were asking before. Okay, so not very important, but at least I would recommend you to remember these common thing. Okay, remember just this 14, 16, 18. Okay, this adult size which we use. 14, 12, 14, 16, 18. So if you want to remember anything, remember the common thing for the adults. 12, 14, 16, 18. Okay, Ishika. Okay, that is sign in. Before the skin incision, now patient is under anesthesia and you want to give incision. Now certain things are done, that is known as timeout. Now you have done the surgery. Before closing the patient and before the patient leaves the OT, you do certain things, that is known as sign out. Okay, so these are the 3 components: sign in, time out, and sign out. Okay, so here answer should be before induction of anesthesia. Before skin incision, time out. Before patient leaves the OT, sign out. Okay. Next question. Match the following. Okay, easy question. Samoma bodies are seen in which cancer? Papillary thyroid cancer. Amyloid stroma seen in medullary thyroid cancer. HLA-B35 is seen in decurvance thyroiditis. Recurrent thyroiditis. In Hashimoto, you can see HLA, B8, DR3, and DR5. And non-Hodgkin's B-cell type lymphoma is 50% of that lymphoma is because of Hashimoto. Okay, majority of the lymphomas of thyroid is secondary to Hashimoto. Okay, so yes, you're correct. Option number A is correct. Option number A is correct. Okay, straightforward. No, there is nothing like time in. Okay, Dr. MS, time in is just given to confuse. There is nothing like time in. Okay, so this is, can you see this picture? Image based. These are like hollow nucleus. This is orphan NEI nuclei. Okay, and these are Samoma bodies. Okay, they ask this in pathology. Samoma bodies are also seen. These are the inclusion bodies. Samoma bodies are also seen in which other condition? Okay, papillary type of RCC. Meningioma. Serous cystadenoma of ovary. And this is amyloid stroma. Amyloid stroma, which is a feature of medullary thyroid cancer. These Samoma bodies and orphan NEI nuclei, these are the features of papillary thyroid cancer. Okay, so that was the answer. Now question number 10. Which among the following statement regarding the renal transplant technique is false? False. Carrel patch is taken from the dead donor. Tell me whether statement A is correct or not. Carrel patch is when you take the main vessel from where the the organ's artery is supplying. So see, this is the renal artery which is arising from the aorta. So if you take a patch of the aortic wall also, then it is known as Carrel's patch. Obviously, it should be taken from a dead donor. You cannot take aorta of a live donor. So this statement is correct. Ureter is kept reasonably short. See, when you do the surgery, see, there are two ways by which you can anastomose the ureter. Let's see. One way is you can create a submucosal tunnel and bring the ureter to the near the trigone. So that technique is known as lead batter polytano technique. But another technique is you give the incision here and do the anastomosis there only. This is known as Lisch-Grigor technique. Now I'll tell you the advantage and disadvantage of both. If you do the Lisch-Grigor technique, there are chances of reflux. And if you make a submucosal tunnel, the chances of reflux are less. Okay, that is the thing. But the problem is, when you do the transplantation, you take out the kidney along with the ureter. Now, if you see, normally the ureter is in the upper 1/3, it is supplied by the renal artery. In the lower 1/3, it is supplied by the branches of the vesical artery, that is internal iliac artery, and this part also retroperitoneal vessels is supplying. But when you take the this kidney, now this this part has no blood supply, the middle and lower part. Only the upper part is surviving because of this renal artery. These two parts, they don't have blood supply. So that's why you try to keep the ureter reasonably short so that it does not go into ischemia and does not go into necrosis. So that's why this is the preferred technique. Okay. Adult donor to small children, renal vessels are anastomosed to aorta and vena cava. Okay, so see, first we see this one. Renal transplant is a heterotopic type of transplant. This is the incision we give, Gibson incision in the iliac fossa, either right or left iliac fossa. And we don't have to enter inside the peritoneal cavity. You push the peritoneum and expose the iliac vessels. Okay, now in general, in general, how we do the anastomosis. Suppose this is renal artery, this is renal vein, and ureter ka to we have discussed, so we will not discuss ureter. The first anastomosis is this vein is anastomosed with the recipient external iliac vein in the N2 side fascia. After that, the artery is anastomosed with the recipient external iliac artery in N2 side fascia. Okay, this is number 1, this is number 2, number 3 is ureter. So this is, you need to remember, if they don't mention whether it is a live donor or a dead donor. Okay, but suppose they mention live donor separately. So this is for dead donor. Or if nothing is mentioned. If nothing mentioned, then also you need to remember this. But if there is live donor, then the renal vein is same. Okay, so I will not write that this is same. This part will be same. But the renal artery is anastomosed to internal iliac artery in end-to-end fascia. Like this. What happens in the deceased donor? In deceased donor, you have Carrel's patch. Can you see there is a Carrel's patch? So if there is a Carrel's patch, it is easy to do end-to-side anastomosis. But in case of live donor, there is no Carrel's patch. So if there is no Carrel's patch, end-to-side anastomosis of artery becomes difficult. Vein diameter is more, so you don't have a problem. But because artery is small and it is difficult to do end-to-side, so end-to-end anastomosis is done using triangulation technique. But we cannot do end-to-end with the external iliac artery, so that's why we use internal iliac artery for end-to-end. Okay, so that is the reason behind this difference. So renal vein anastomosed to end-to-side external iliac vein, anastomosed to end-to-end recipient internal iliac vein. If taken from here, should be a, this is the wrong thing, live donor. This statement was for live donor, it is written dead donor, so that is the false statement. Okay, like I say that this thing will be asked only in INICET. Only the AIMS people, they can ask this question. So that's why I had put deliberately in this. So only INICET people can ask this. The difference between the anastomosis of vessel in the live and the deceased donor. Okay, next question. Abdominal compartment syndrome is characterized by the following except. Okay, so in abdominal compartment syndrome, okay, let me use another page. See, in the abdomen, normal intra-abdominal pressure is 5 to 7 millimeter of mercury. If it is more than 12 millimeter of mercury, it is intra-abdominal hypertension. And if the intra-abdominal pressure is more than 20 millimeter of mercury with end organ dysfunction, then it is known as abdominal compartment syndrome. Definitive closure of the abdominal wall in which phase of DCS, phase 3 or 4, if both are in the option. If they have mentioned phase 4, then that would be the better answer. If phase 4 is not given, only phase 3 is given, then phase 3 is the answer. Given both 3 and 4, phase 4 is the better answer. Okay, Shivangi. Okay, so what happens, what changes can be seen? I'll tell you the important changes. When there is increased pressure, this pressure will equally exerted on all the walls. Okay, this is known as Pascal's law. So because the pressure is going in the diaphragm, so there will be increase in the end inspiratory pressure. Okay, you can say peak inspiratory pressure. So that will lead to hypoxia. Patient will have atelectasis and there will be carbon dioxide retention. So that's why hypercarbia is seen. There will be increased pressure mainly on the renal vessel. In renal vessel also, it is mainly renal vein. So because of that decreased blood supply, there is decreased urine output, decreased GFR, and increased pressure on IVC. Because of that, there will be hypotension, there will be tachycardia, there will be increase in the peripheral vascular resistance, pedal edema, all those changes you can see. And because there is increase in the intrathoracic pressure also, because now the diaphragm coming towards this side, so definitely thoracic pressure will also increase, and because of the increased intrathoracic pressure there will be decrease, you can say, the venous return from the brain, and because of decreased venous return there can be increase in the intracranial pressure. So these are some of the important changes which are happening. Although I have given one picture also, there are so many changes, but I'll just highlight the important change: increase ICP, decrease in the cerebral perfusion pressure, increase in intrathoracic pressure. Okay, then in pulmonary, decrease PO2, increase PCO2, hypovolemia, decrease cardiac output, decrease venous return, increase peripheral vascular resistance, decrease renal blood flow. So many systems are involved. These things are the important ones. Okay, and remember, how do you measurement of intra abdominal pressure? Measurement. Put a Foley's and fill the bladder with 25 ml saline and attach to the manometer and measure at end of expiration at level of pubic symphysis. So you have to put a Foley's catheter, fill 25 ml of saline and settle the zero at the level of pubic symphysis and measure at the end of expiration the pressure. Okay, so let's see the question. Except hypercarbia is seen, hypoxia is seen, hypotension is also seen, oliguria is seen, but not because of the ureteric obstruction, but because of decreased renal blood flow. The answer will be D. Answer will be D. Okay. Next question. 40-year female, increasing lump in the parotid region. Tonsils was pushed medially. Tonsils pushed medially. Biopsy showed pleomorphic adenoma. See, pleomorphic adenoma, what is the treatment? Superficial parotid. But if this tumor, if there is involvement of deep lobe, now how will you know that there is deep lobe involvement? Tonsils are pushed medially. So tonsils pushed medially, deep lobe involvement. You have to remove the superficial as well as the deep lobe, but you need to preserve. You have to preserve the facial nerve. So that is known as total conservative parotidectomy. Okay, option number C. If tumor involves facial nerve, what is involving facial nerve? Generally, the malignancy, mucoepidermoid, adenoid cystic more commonly involves the facial nerve. Then you have to remove superficial lobe, deep lobe, as well as a part of facial nerve. That surgery is known as radical parotidectomy. Radical parotidectomy. Okay, so that's why the answer to this question is C. Total conservative, because there is involvement of the facial nerve. Why we are saying there is involvement of facial nerve? Because there is involvement of deep lobe. Why we are saying deep lobe? Because the tonsils are pushed medially. Okay, very nice. You are answering correct. This is an easy question. Okay, let me write 2-3 things. Most important landmark to identify facial nerve during surgery. Okay, I want you to answer this. Most common nerve injury in parotid surgery, submandibular. 3 questions. Tell me the answer. Most important landmark to identify facial nerve. Tympanomastoid suture. Most common nerve injury in parotid, crater, auricular. Most common nerve injury in submandibular, marginal mandibular branch of fascia. Okay. Next question, a easy question. Involved in road traffic accident, brought to the surgical emergency. HRCT was done, showing multiple rib fractures at two sides. True about this condition are all except multiple consecutive rib fractures. It is flail chest. By definition, fracture of two or more than two ribs at two locations. Yes, correct statement. Ultimately leads to respiratory failure. Yes, if you don't do any treatment, there is, because of the pulmonary contusion, it can lead to respiratory failure. Paradoxical respiration is seen, but there is no mediastinal shift. Okay, you will not see any mediastinal shift. Okay, it is not causing any collection, neither there is collapse. There is just, you can say in that part, there is pulmonary contusion. Okay, pulmonary contusion. So no mediastinal shift is seen. Probably the easiest question. Treatment if there is no respiratory distress, oxygen by mask, and analgesics. Okay. Epidural, thoracic epidural analgesia. If there is respiratory distress, endotracheal tube, and put the patient on intermittent positive pressure ventilation. Intermittent positive pressure ventilation. Okay. The difference between a keloid and a hypertrophic scar includes all of the following except. See the question, try to see the language. Presence of antinuclear antibody against fibroblast. Yes, this many people they believe keloid to be an autoimmune disorder, and because of that antinuclear antibody against this. So it is present in keloid, not seen in hypertrophic scar. Okay, so this is, you can say, has one difference. Collagen bundles with a glazed appearance. Collagen bundle in keloid disorganized, glazed. In hypertrophic scar, it is in parallel fashion. Okay, so this is also a difference. Scar limits. Keloid, hypertrophic scar. Keloid goes beyond, or you can say it outgrows the boundary. Hypertrophic scar does not outgrow the boundary. The predominant collagen is type 1. In keloid, yes, type 1. In hypertrophic scar, yes, type 1. So this is not a difference. This is same, and that is the answer. That is the answer. Okay, so there is no difference here. That is the answer. Okay, any confusion in this? No, nothing. All good? Okay. Coming to the last question. The patient presented to the emergency history of RTA, NCCT, and NCCT shows this picture. What is the indication for surgery in this particular patient? Okay, so this is very obvious. This is extradural hemorrhage, extradural hematoma. Okay, you can say biconvex or lens-shaped opacity, lenticular, because of injury to the middle meningeal artery. And the shape is this because it does not cross the suture line, but it may cross midline in the frontal and occipital region. SDH, on the other hand, which appears like this, it is concavo-convex or you can say moon shaped concentric bridging veins, bridging or communicating veins can cross the suture line but does not cross the midline. Now the question is about EDH, so let's see indication for surgery. Okay. Indication for surgery like craniotomy, craniectomy, if the GCS is 8 or less than 8, any focal neurological deficit like hemiparesis or pupillary dilatation, midline shift 5 or more than 5 mm. These are the main ones. Then volume of the hematoma more than 30 cc and thickness of the hematoma more than 15 mm. Okay, so given options here, let's see. GCS fall of 2 after admission is not an indication for surgery. Obviously, you should get the scan again if the GCS falls. Midline shift of 5 mm is the answer. High velocity impact, eye opening on pain is not any indication. Okay, so these were like those 15 questions of the INICET Predictor series, and I can see in your comment box that most of you have answered the questions correctly. Okay, so I'm very hopeful. I'm very sure that you will do very great in this upcoming INICET. Okay, so best wishes to all of you for the INICET. There will be around 25 questions of surgery. Read the question carefully, read the options carefully. Make sure you are reading the correct thing, that whether they are asking the correct statement or the wrong statement, whether it is a single answer type or the multiple answer type. Don't do mistakes in a hurry, okay, because nobody will. I have not heard any person who could not able to see all the question. There will be good enough time, plenty enough time for you. So all the very best for your exam, and we'll meet again in the after your INICET. We'll discuss what type of questions were asked. Okay, so my best wishes to all of you. Thank you very much.